Good afternoon, everyone. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At the moment, all participants are in a listen-only mode. For those that are connected by telephone and require operator assistance during the call, please press *0. For those online that require assistance, please use the chat box on your screen. I would like to now hand the meeting over to your host, Christine Quinn, Director of Strategic Initiatives at the Canadian Foundation for Healthcare Improvement. Please go ahead.
Thanks very much. Hi, and welcome to our webinar today, Stakeholder Perspectives on How Artificial Intelligence, or AI, can and should be used in healthcare. My name is Christine Quinn, and I'm the Director of Strategic Initiatives at the Canadian Foundation for Healthcare Improvement. And as some of you may know, we have recently amalgamated with the Canadian Patient Safety Institute to achieve safer, higher quality, and more coordinated patient-partnered care. And we really look forward to introducing our new organization to you in the coming months. I'd also like to let you know that I'm joining you today from my home office here in Peterborough, Ontario. And I would respectfully acknowledge that I live and work in traditional territory of the Mississauga Anishinaabe. And I offer my gratitude to our First Nations for their teachings and really look forward to honoring those teachings as we continue our learning today. We have participants joining us from across the country, so if you haven't already done so, please do take a moment to share with us where you're joining us from in the chat. And just a couple of housekeeping items as we begin. First, we are pleased to bring you today's webinar in both English and French through simultaneous interpretation. And so to ensure that you are listening to the program in your language of choice, please follow the instructions on your screen in the audio box that will ensure that you're connected appropriately. Secondly, I do want to encourage you to use that chat box throughout this program. Share with us comments, pose questions, share your reactions. And thirdly, we want you to be social. Hey, we have a hashtag for this event. So share your thoughts, experiences, and any relevant resources related to today's topic using the hashtag AI-driven health. We've got such a rich webinar for you planned today, and we have a whole crew of folks behind the scenes who are really going to be working hard to make sure that they're synthesizing and organizing your questions and making sure that we have time for the panel to answer. But should we run out of time, don't worry, we will close the loop and we will share a summary of today's discussions and get back to you with some of those unanswered questions following the webinar. So today, we're going to start with defining AI and introducing its role as a diagnostic, treatment, and preventative tool. And you're going to hear from a variety of perspectives from a number of different stakeholders. And then we hope to uncover AI's potential and enablers for adoption. So as I said, we've got a fantastic lineup of speakers, and we're going to bring you many voices. Our panelists today include health system leaders, a patient partner, providers, and researchers from across the country. And I'd like to right now, I'm absolutely thrilled to introduce you to our host and panel moderator for today's webinar, Dr. Alexandra Greenhill. She is one of Canada's leading physicians in digital health innovation, and she's the recipient of the Canadian Medical Association's Jewel Award. Dr. Greenhill currently serves on CIHI's board. She's the chair of the board for Physician Innovators Canada and Global, and is currently the CEO, Chief Medical Officer of CareTeam Technologies, a next-generation virtual care collaboration platform. Welcome, Dr. Greenhill. We are thrilled to have you today. Now I'll introduce you to some of our panel members. First, I'd like to introduce you to Annette McKinnon. Annette joins us as a patient partner. She lives with a chronic condition, and she shares her perspectives and experiences to ensure that the patient voice is included in healthcare decision-making. She's a partner on several research teams, and she's the founding member of the Patient Advisors Network, which is a community of practice for patients and caregivers. Welcome, Annette. We're also joined today by Dr. Reza Forghani, a diagnostic radiologist and recognized clinician scientist. He is the director of the Augmented Intelligence and Precision Health Laboratory of the Research Institute at McGill University Health Center. Welcome, Dr. Forghani. And I'd like to also introduce you to Mary Akenhuizen. She has held the role of President and CEO of Vancouver Coastal Health from 2014 through to this year, and she currently holds the appointment of Senior Executive in Residence and lead for the Partnerships and Innovation Division at the BC Ministry of Health. Welcome, Mary. Next panelist is Dr. Tracy Rissling. She's a registered nurse and is currently the Interim Associate Dean of Research and Graduate Studies at the University of Saskatchewan College of Nursing. As well, she is the President-elect of the Canadian Nursing Informatics Association. She explores how health technologies influence patient empowerment and engagement, and is really interested in increasing nursing engagement in the development and deployment of digital strategies. Welcome, Tracy. Next, I'd like to introduce Dr. Brendan Carr, an experienced health executive and emergency department physician. He has served as Vice President of Medicine for Capital Health in Halifax, President and CEO at Vancouver Island Health Authority, as well as at William Osler Health System in Ontario. And presently, Brendan is the President and CEO of the Nova Scotia Health Authority and the Director of CADIS, as well as the Canadian Society for Physician Leadership. And our last panelist that I'd like to introduce to you is Dr. Richard Resnick. He is a surgeon by training, and he is the inaugural director of the University of Toronto Medical Faculty's Centre for Research and Education, the VP of Education at the University Health Network, and more recently, as Dean of the Faculty of Health Sciences at Queen's University, and Chief Executive Officer of the Southeastern Ontario Academic Medical Association. So as you can see, we have quite a panel lined up. We've got some opportunity for vibrant discussion, and I would like to take this opportunity now to hand it over to our panel moderator, Dr. Greenhill, to give us an introduction to AI and its current state in Canadian health sector. Over to you.
Thank you so much, and it's an exciting conversation because we've lived through the winter of AI, meaning when it was first invented, people got very excited about it, and then in the 80s you realized that, well, we can't quite use it yet, and so a lot of people got discouraged. And so this cycle that Gartner has put together illustrates that sort of initial peak of expectations and then the gradual re-excitement that's happening right now as AI moves away from being science fiction into being something that we can actually use in daily life. And we already use without often realizing it every time we do a Google search or use some of the technologies in our consumer life, and increasingly as physicians and clinicians and patients. And so the exciting piece about this is Canada actually has played an incredible role in that journey with CFAR in 1983, deciding against everyone else to invest in that area, which led to some of the developments with Geoffrey Hinton and Yoshua Benghi receiving the Turing Prize most recently and being named the godfathers of the deep learning AI space. And so very quickly, and I know that some of the people responding to the panel said we already know and how proud we are of the Canadian history in this space, is the CFAR funded 3 organizations, NILA and AMI and Vector Institute, and then the Supercluster Initiative, the Digital Supercluster here in Vancouver and the one in Montreal, Scale AI, and many other things that we will share the links for after the session. But the fundamental question then becomes, share document, no. Well, when we can get back to the slides, is the perception that people have right now within the sector is that, AI is this nebulous cloud where you put in data and somehow miraculously comes out expectations. And the reality of it is far from that. Is you have AI, which is an evolution of statistics, of data science, where you actually have an assessment of probabilities that just happens really, really fast. And one of the most exciting developments has been quantum computers, which can essentially deliver in a day something that would otherwise take 3 to 6 years sometimes to produce. And so that is where we're going forward, is that sort of a common understanding of what AI is. Even though it's a bit of a black box, more and more people should become aware of where the origins are and stop being as afraid of it as they are. And so this little graphic that we put together sort of starts illustrating all of the different things that people call AI, but in fact are subtypes of AI or may not even be true AI, artificial intelligence per se. And so if you think about the continuum on the left from machine to human, you have data science, which is the analytics and statistics. Then you have machine learning, which is a little bit more of a sophisticated element of data science with machines developing their own learning based on the data that they see. Then you have artificial intelligence, which encompasses some of that. Within that, you have deep learning. Then you have augmented intelligence. Then there's artificial general intelligence. And no one really agrees on the definitions of these. And so therefore, it's really important for us to acknowledge that while we are forming this new science, there will be some misunderstandings and disagreements, but the AI that we refer to for the rest of the panel includes all of these in some form. And so it's the evolution of moving away from doing everything by hand as humans and trusting machines to automate and facilitate some of it to some extent, and potentially down the road in the future make autonomous decisions. But the AI we're talking about right now is largely human in the loop, includes a human as part of the definition. And so, when we say AI, we may mean different things, and one of the important caveats in the dialogue as you go forward is to clarify, what does the other person mean by the term that they're using. And so for the purpose of our discussion, we're going to go next to panelists and review in a completely different frame what their impressions are about the future potentials and downfalls of AI. And so Annette, if I can ask you to unmute and share a little bit more about your perspectives on that sector.
Thank you. Can you hear me?
Yes.
Great. I have my hopes and my fears. I think that AI and machine learning have helped to make the COVID vaccine development so fast that people are even skeptical of the vaccine because of the record-setting speed. Another potential area of use is patient safety. Just one innovation that can intelligently lower alarm frequency by 90% could lead to fewer falls, safer medication dispensing and delivery, and more efficient and happy staff. And it exists. We also see it used for providing data-driven care in staging cancers, saving weeks. And in radiology, AI learns from millions of images rather than just a few thousand. My wish is to see it used to give me a coherent electronic record. I would see that as a direct benefit to patients and a benefit to the health system, but I'd like to have a benefit that was tangible and useful for patients.
Thank you, Annette. This is great. Dr. Forghani, over to you.
You hear me?
Yes.
Perfect. So I'm hopeful that AI will enable an unprecedented level of quality and precision care that's more cost efficient and sustainable. From my perspective, if done appropriately with proper foresight, AI may help align competing interests, which include those between quality and cost, that have been and will continue to be a challenge. And this will result in overall improved quality of care as well as sustainability. I do think AI has the potential to enable a new milestone in precision and personalized care. Globally, AI may make available certain tools, for example, basic diagnostic interpretation tools, to underserved areas where experts such as radiologists are sparse or not at all available. Lastly, the other thing, and I think Dr. Greenhalgh alluded to it importantly, that we should not overlook are the important health technology infrastructure improvements that will have to be done in order to implement AI, themselves having significant potential for improving health delivery, even independent of any machine intelligence components.
Thank you so much, Dr. Forghani. And as speakers come on the panel, please just activate your webcam and unmute. And so over to you, Mary Eckenhusen, over to your hopes and fears about the space. We can't hear you, so unmute maybe. Technology is going to get better, and soon we'll be able to understand each other's thoughts. We're not there yet.
You can't hear me now?
Yes,
No.
yeah. Thank you.
Yeah. Good. We had huge pressure on them. No?
Okay, now we can.
Even before, okay, right to my mouth. Even before COVID, we had huge pressure on the system in terms of being able to meet the demand of all the elderly, chronic disease patients, et cetera. And our challenge as we move forward is, even post-COVID, is going to be the same one, that we really don't have enough resources in the system. And I'm not just talking about financial resources, but actually human resources. So we see that now in Canada and in the States, that we have beds that we need for COVID patients, but we can't open them because we don't have the staff. And that's only going to get worse. The World Health Organization has forecasts both for developed and developing countries, so OECD countries like our own, that by 2030, 1 in 5 positions in the healthcare system will be vacant. And so that it is my hope that artificial intelligence will fill a big part of that gap, because we won't be able to just hire more people, which is what we're really trying to do right now. And we'll find that artificial intelligence can make our lives simpler, both for clinicians and for patients, because it will do some of the jobs that humans do right now faster and more cost effectively. So that's my hope. But we do know that in Canada, as much as this panel is extraordinary, some of the people and what they know about artificial intelligence, we are not leaders in adopting technology, particularly for healthcare. And we're not even fast followers necessarily. And we may get very twisted up in ourselves looking at all the complexities and the challenges of this new way of thinking. And there are some that we'll talk about. So privacy, security, the ethics, will it take away my job? All those are real fears, which we can address, but I fear it's going to slow us down, and we won't realize quickly enough the value of artificial intelligence, which to me is one of the very key things we need to adopt in order to maintain a quality and sustainable healthcare system. Thank you.
Wonderful comments, and it will be interesting to see what we unpack in our conversation. Over to you, Dr. Risling.
Thank you so much. You'll see here on my slide that my shiny hope for our AI healthcare future is that it delivers the analytic capacity to allow us to see the forest and the trees. And this is where I state my own bias, that as a health informatics researcher and the president-elect of the Canadian Nursing Informatics Association, also a long-time early tech adopter, I have a pretty sustained enthusiasm for the potential of AI in healthcare. It's something I've been writing about, talking to nurses and patients about for almost 3 years now. And there's such a believable ring to the certainty of AI that it can drive this sweeping change in healthcare around the world. And it's so easy and enjoyable to get caught up in that, especially for tech geeks and fellow tech geeks like myself, to get drawn into this future. You may notice it's a very shiny future, lots of reflective surfaces every time we see this depicted in any kind of video or pictures. And we've had some really compelling early promises served up when it comes to AI and healthcare, like by Eric Topol in his publication Deep Medicine. In 2019, a great resource if you haven't checked that book out yet. There's a great audio version as well. It's a case study approach to presenting information that AI ultimately will free up time for more humanity in healthcare, more time for deep care and connection in our health and medicine. And this is a sentiment we recently took an updated look at in a report that was commissioned by the Registered Nurses Association of Ontario and AMS Healthcare on nursing and compassionate care in the age of artificial intelligence. It was released just last month, and I'll probably tweet that out shortly here as well. But it really talked about the way that AI is very likely to change nursing practice, education, research, administration. And as nurses, I think we really hope for that future that allows us to address the deficiencies we know are part of our existing system. But in order to do that, we really need to use this technology to see the forest and the trees. And actually, I would prefer each and every single leaf. And by that, what I mean, and as we cross over onto my fear side, is that I think one of the things we really need to look at carefully is our healthcare data. because what I tried to depict in this sphere slide is my understanding, and again, I have to say too, not the AI tech expert on the panel today, but when I think about how we bring this into our system, how we operationalize the promise of AI, this isn't just going to be a weekend renovation, right? We're going to have to move back down to the foundational and structural elements. And we are engaged already in a global exploration of AI advancement that includes important things that have already been mentioned, like ethics and bias. And in our work, we looked at digital determinants of health, trying to explore equity for connecting people to a digital health future. Now we're looking very new, only in the last few weeks, at this idea of compassionate data and how we shift data and representation in data to help address inequity and bias in AI. But like Annette, my hope is that AI can be used to equip the players on both sides of the clinical relationship, that we use these tools not just to enhance diagnostics and decision-making for clinicians, say for example, but also in that timely and complete sharing of healthcare data so that patients and families can be more engaged, better informed, and more equal players in their own care.
Hear, hear. Well said. Dr. Brendan Carr, over to you.
Thank you, and good afternoon, everybody. Well, my hopes and fears, I think, are pretty simple. My hope is that that AI will really have an impact for all Canadians, no matter where they live, and that it will have a positive impact, I guess, in their ability to access appropriate care, for them to understand their health and to manage that. And so, you know, in the background of that is not so much a concern, but just a recognition that there will be a natural tendency for AI to develop in certain settings, probably focused on some very interesting and highly specialized challenges, and all of that is really important and will be valuable. But I guess my hope, though, is that we will get to the point where AI is having an impact for just the average person where they live. And this picture that I've chosen is a picture from a community just down the road from us where people live. My fear slide is also kind of simple. I mean, I think it reflects that healthcare, maybe unlike some other industries, we are very much hardwired to see the work that we do through an improvement lens. And so we typically approach everything from the point of view of, I'm going to start with what I'm doing today, and I'm going to just make that better so that to improve patient care. And my concern is that I think if we let it, AI, is something that actually can help us to really completely redefine, reimagine, and really think very differently about not just our care processes, but just how the system works for the people that we serve. And so I'm hoping that we will be able to manage this tendency to want to focus a lot of energy on situating AI within our current processes, and that we will actually allow it to liberate us a little bit and really think about where the opportunities are for AI to really profoundly allow us to kind of reimagine care. Thank you.
Thank you, Dr. Carr. Dr. Resnick, over to you.
Well, thank you. And I'd first start off by saying to Tracy that I've worked with nurses my whole life, and I'm married to a nurse, so she won't be surprised to hear my comments resonating with her and the rest of the nursing community. I agree that about what Topol had to say and reminded us of the gift of time. And this gift of time, I think, may be one of our greatest hopes. Our task force heard loudly and clearly that AI is coming fast. And while we all agree, I think, that AI won't replace doctors or other health professionals for that matter, one of the quotes that resonated with us in our task force was that doctors who don't use AI will be replaced. The freeing up of time from routine tasks that will allow clinicians to focus on higher order activities, including clinician-patient relationships and compassionate care, I think is our greatest hope. But as I mentioned, the last thing I'll say on the hope side is that we don't think AI is going to replace doctors, and one of the remits of our task force was to comment on the number and complement of medical specialists in Canada, and currently we don't think that should change. On the fear side, the task force I chaired focused a lot of our time on the issues of fairness, on ethics of AI implementation and social accountability. Given that patients will have access to their own data, coupled with natural language capabilities, we think AI can be a true democratizer of healthcare. AI has the potential to drive data-centered partnerships between clinicians and patients. But as others have mentioned, there's a digital divide out there that could well negatively impact marginalized populations. And as well, data being at the heart of AI, and we know that Canadian data is not always derived fairly, it might lead to a risk to the quality and safety of patients who come from historically underrepresented populations.
Thank you so much, Dr. Reznik. And it was interesting to read everyone's comments in the chat. Please keep them coming with comments on your hopes and fears and how they're resonating or developing ideas beyond the ones shared by the panel. We were asked to choose from sort of hundreds of images, and I did choose the same one as Dr. Reznik did myself, which is that sort of idea that right now we have a number of tools that are completely disconnected, but what AI adds that data doesn't is the ability to create insight, is not just to collect all the information in one place, which is what the previous technology stack allowed us to do, but actually to start generating meaning and understanding so that we can see the forest for the trees and the trees for the forest, and from whatever perspective we're approaching. So fully resonate on that. The image on the right I selected because a part of the concerns that were shared before is I echo, which is because we're so worried about some of the negative impacts, about the privacy, the discrepancies, the inequities, that we may spend too much time thinking as opposed to doing, and the progress of adopting these new technologies will be as slow as it was for digital technologies, and so we are behind in the healthcare sector relative to all other domains in life. I don't know another domain that uses fax on a regular basis, and yet I was e-faxing patient information this morning in my clinical practice. And so it's time for us to figure out how and what we can do as a system to start adopting some of these ideas faster. And that's exactly where we're going to go next with our panel discussion. And so the first question we have that we wanted to tackle was that question of what and how we can do to implement healthcare faster in the AI sector. And I'm going to go to Dr. Reznik first for a quick aperçu on that. And please write in French in the chat if you need to. You know, this is a bilingual session. You can ask questions in French as well. Je suis francophone, and many of the speakers on the panel are as well, so we'll be able to answer in French as well. Dr. Reznik, over to you.
Okay, well, thank you. As mentioned, I think we all think AI is coming quickly to healthcare. In fact, it's very much here in many respects. What our task force learned, however, is that we certainly as a medical profession, we're just not ready. And when we looked at both our undergraduate and postgraduate curricula for future specialists in Canada, it's clear that even basic education relating to the fundamentals of AI is glaringly absent. If it's axiomatic that AI will only work as a true partnership between AI scientists, engineers, computer scientists, and clinicians, we believe that, and we believe that to be true, then one of the most important enablers is preparing future specialists to be AI ready. And that means that digital literacy, at least for us at the Royal College, needs to be a fundamental competency of all future graduating specialists. Basic education on AI needs to be part of every curriculum.
That is a great point, Dr. Reznik. I'm going to go over to Dr. Forghani on another perspective on the same question about how can we do things faster. But what I heard you say is, digital literacy of the professionals is at every level, clinicians, researchers, and others, is a must. And yes. So we have quite a task ahead of us.
We do.
Hi, I think when it comes to AI implementation, I do think that the technological barriers are significant. So while we have a lot of AI tools, if you look at them, many of them are in the theoretical stage, especially in Canada. And there are advantages to our system, but also disadvantages. And sometimes our system, AI is very fast moving. Even if you look at different industries, let's say hardware industry, they can barely keep up with a field that will change within 6 months. And our traditional decision-making structure, let's get elected, we promise, we form a panel. If you do that with AI, you'll have missed the full boat. And I think to integrate that, I think we just have to be practical. I do think we will have to engage industries. It's not a simple thing, but with the right safeguards, I actually think it's the only way. Because when you talk about AI, first there's a whole data infrastructure, but there's also the major and important thing of data security. And again, when you have companies with multi-billion-dollar budgets, there's no point for us recreating those. If we focus on recreating what we don't do well, we're going to miss out on the applications. I really think we need to partner, and we need to do what we want to do, is healthcare implementation.
So part of the way forward that I heard you say, Dr. Reznik, is, Dr. Forghani, is the way to collaborate across the traditional boundaries and include private sort of representation from companies who can enable us to go faster, but also need to learn about some of the ways of healthcare and the need for science and research and evaluation before things launch.
I agree. I think this is to be from a practical perspective. If we don't want this to be a theoretical exercise that people lose interest in, I don't see any way around it. Just if you think of a hospital's form, if you're going to implement a new technology, I also think we need to go into some uncomfortable areas. For example, data has value. Now there's a lot of debate, should you get value, or should you monetize data? And you don't want to do that in a bad way. But if you think we're a public system, everybody benefits from a system, that actually gives us some leeway in leveraging that. Again, if we don't leverage things, we don't have infinite resources. If you don't get realistic, and if you don't answer the hard issues, who really loses out are the Canadian public, who have to wait for access, who cannot have access to home care, to have all these deficiencies, right? And, we don't have infinite resources. So I do think that we have to be bold and go and really explore and find the right balance in those uncomfortable areas to make this feasible.
Excellent. Well, Dr. Riesling, if I can call on you to complement that perspective of what would it take to actually implement some of these exciting innovations that I agree, I usually describe as shiny, but our realities in healthcare are not there yet. So how can we accelerate that desired future?
Well, Dr. Reznik took my curriculum plug there, but it's such an essential piece, right? And I always ask myself, how do we translate the pace of technological change that we see? If we really believe that AI is that rapidly transforming our healthcare system, how do we translate that into our healthcare curriculums? And I got to tell you, in my experience in nursing education for almost 2 decades now, I got to say the pace of curriculum change is not fast, and that honestly we didn't do a great job in terms of just integrating foundational digital health curricular changes across those healthcare curriculums. But Dr. Reznik gave a very elegant summary of that challenge. I think in 2019 when Eric Topol put out Deep Medicine, everyone was quite excited about that, and there was a lot of focus on that. What I really think is valuable for us in this discussion and for Canada in general and for practitioners is actually to look at the other document he put out in 2019, which is a report that he did for the UK, the United Kingdom Health System, the NHS, talking about how to prepare and support healthcare workers to deliver a digital future. And there is some really brilliant sections in that about AI, about trust, about patient partnership, co-design, which I think is an essential element, and data. And I think the last point that is a sticking point, but where we could put some concentrated effort into is standardizing data and data sharing, right? Nursing has been engaged in standardizing data because of the fear that, at least in the current electronic health record, nursing is not well represented, and that's a data issue. If you don't have good, strong, standardized data, you're not going to have an ability to influence AI systems or machine learning systems that are driven by data. So we need to think about that. We need to think about how we share data. And lastly, I'll say, I think we need to think about what we consider to be healthcare data. Twitter's having quite a bit of fun this morning about a piece that's emerged about how beginning in January, all of the reviews of scented candles of a certain major global online marketplace have started to downgrade, with the speculation being that maybe all of these reviews on scented candles were changed because people with COVID symptoms that included an inability to smell didn't think very much of their scented candles. Now, whether or not this speculation plays out to have any reliability or validity or value in our discussion of how we use data mining in predictive analytics and other tools of AI, I think what it does do is remind us that if we're going to really capitalize and look into a future of systems that have the capabilities to use massive amounts of data to help us see things and make decisions, maybe we need to better consider what kind of data we want to input into those systems.
Wow, lots to unpack in this, but I'm going to go back to you next with the next sort of a panel, but just on the idea of educating the workforce, so to speak, in healthcare. In addition to curriculum reform, I think that's one of the intents behind this particular webinar and all the other activities that the Canadian Foundation for Health Innovation is doing, because not only should we educate the future of the professions, but also figure out how can we mainstream some of that knowledge to everyone who's already actively involved and so busier than ever with COVID, but also, you know, the crisis has led to an opportunity and for people to realize that more of the same may not be the answer, that we need to come up with new solutions. And so stay tuned, everyone, for more to come from the CFHI in this initiative. There'll be more webinars along this, unpacking different elements of things that were just raised by the three panelists who spoke. So switching gears a little bit, just in the interest of time, this is meant to be an introductory sort of a what are the hot issues in the space. I'll stay with you, Dr. Özving. How do you see the ability for us to partner across? You mentioned nurses. I think patients and caregivers are also underrepresented. And so how can we use some of these new emerging AI-based technologies to improve how we communicate and collaborate and partner?
Well, I think one of the first things that we need to do, and we actually had a publication earlier this year that just talked about co-design. And again, it's one of those, like digital literacy, having both nurses, other healthcare practitioners, and our partners, and by our partners I mean engineers, computer science, industry. Everyone is going to need to look at co-design, have a foundational understanding of co-design, and Eric Topol returns to that point in his report for the NHS as well. It has to be a collaborative effort, because some of the challenges related to AI are related to trust, to buy-in and to execution. And we've seen challenges in our existing digital system that have resulted from a lack of co-design and a lack of partnership. So whether or not the AI systems themselves create new opportunities for us to collaborate, they certainly create new conversations like scented candle reviews. I mean, right, like we don't have those kinds of conversations without an ability to aggregate that kind of data. But for me, for someone who has spent so much time in partnership with patients getting basic foundational data out in more closer to real time to patients, and across, I think these systems, if we use these systems correctly as the final push to improve data interoperability and sharing and real-time sharing, and that sharing includes not only all members of the healthcare team, but patients as well, then you're right. I think if that's the if that's the catalyst to take that final step and really deliver on those promises that we've been working on for so long, then I think we'll have something we can really work on for the future. And because that data has to be reviewed, like people need to be able to interact, to see that data, to make comments on that data in order for us to enhance the systems as we go. So this is a really collaborative need and a collaborative process. And I think, you know, one of the things that we're talking about in nursing is a better understanding of co-design, again, that applies not just to new practitioners or clinicians in training, but creating those opportunities in acute care practice, communities, all across the spectrum of healthcare delivery, so that everyone potentially has a say in how AI helps us evolve Canada's healthcare system.
Wonderful. And so I'm going over now to Annette McKinnon from the patient perspective, but I love the words you mentioned, co-design. And so people in the webinar are not quite familiar with that. It was the sort of the movement in the Valley, Silicon Valley, that sort of started with the idea that part of adoption issues have to do with the fact that you didn't quite understand what the end user needed. And so co-designing means a collaboration at every step of designing the tool, and not just a one-time interview at the very beginning and then you go off and you build for a year and a half and develop something that then doesn't work in real life, but it's this collaboration that needs to occur between everyone. So Annette, over to you. I love the movement to not just patient, but also person. The latest report that CFHI and the Patient Safety Institute produced on the importance of caregivers and being as caregiver inclusive as we are person inclusive. See if I can get you to go back on video and unmute and maybe share your perspective on that question of how can we use some of these new tools to increase the opportunities to partner in healthcare.
If I'm not on video, I don't know how to get back there. But what you're talking about with co-creation and co-design is absolutely important to me. And anytime I say patients, it usually implies caregivers and not only family caregivers, but whoever the patient chooses. And so I'm saying that as partners in the health system, we can have a positive impact on it through co-design. It's crucial to the success of the health system that we invite patients in, and if not co-design, at the very least, at the lowest level, to share opinions on where and how we need to innovate. So I'd like to see AI used to help patients move from the disempowerment of sickness and chronic disease towards having the power to self-manage and to be a significant part of their own healthcare team. And it looks like we've all been reading Topo lately. I looked at a study of discharged patients where one extra home care minute reduced readmission risk by 13% when you were discharged from acute care. So that shows that an upfront investment of time pays dividends through improving outcomes and reducing costs. So if we used AI and its natural language processing feature, we could make this happen by freeing doctors from the electronic health records, from the incessant data entry, and giving them more time with patients. But then what we have to do is we have to balance the patient interests against the health budget concerns and the politics of volume in healthcare. Thank you.
I love, Annette, that you brought back the point that was made earlier about time. I think it was Dr. Resnick who had as one of his hopes for AI and the ability to create more time for meaningful relationship and conversation between the clinicians and the patients. And hopefully we can sort out your video issues so we can have you back on video a little bit later on in the program. Over to you, Mary Atkinghausen, if I can have you back on video and unmute. You've worked in every dimension of the healthcare system, and so I love the fact that we get you to close off a little bit that conversation about how can AI enable us to partner better across the system.
Thanks. I think I'm having the same problem as Annette. Maybe it's a common problem because I used to have a little tab that says to go
undo my video, but I don't have it anymore. So I'm just going to continue so that we don't lose time. I'm going to build on what Dr. Resnick said. He was, oh, maybe there we go. In terms of democratizing healthcare. So just to unpack that a little bit, what does democratizing really mean? I mean, that's what we have seen across so many different industries over the last few decades, where you take something that's very complex and really only able to be led by experts, such as physicians, and you make it, you routinize the complexity, the intelligence of the leaders in the industry. So we saw that in computers, where you used to in the 60s have these huge computers that filled up a whole room that could only be run by PhDs. And now you have the computer that's on your smartphone that's equivalent and greater in power. Travel agency, used to have to go to a travel agent to get your whole trip plan. Now you do it yourself. We see it in banking, et cetera. So that's the promise of AI for healthcare, in that you or we as patients and families of patients will be able to do so much more on our own, whether it's in the area of health prevention or diagnostics or post-surgical treatment, whatever. We're going to be able to do a lot more on our own, because we'll be supported to do that through tools that incorporate the intelligence of clinicians. Not to substitute for clinicians. I also like what Dr. Resnick said, and that it's determined that we need the same number of physicians and clinicians in Canada as we do currently. And that's so absolutely true, because the demand is skyrocketing. So we need to make sure that that same number of clinicians can actually support a much higher rate of demand, which is what the AI will allow to happen. And so, again, the good, the clinicians who have gone into healthcare because they're compassionate, because they want to, they're compassionate, they're intellectual, they strive on the complexity, they can do all that and do that as a much greater part of their job than they do today. So that's really how it will help patients. And I guess the last thing that I would speak to that I think of when we say partnerships is this will require partnerships with private sector, which, it's a bit obvious that this type of skill set doesn't exist easily in the healthcare system, and frankly it's too scarce and expensive to easily hire into the healthcare system. So our system will have to learn to become good partners with private industry, which frankly is not easy right now. We seem to have a fairly deep-seated suspicion of private industry and the private sector, which I think we're going to have to get over, because a lot of the tools, the answers, the skills are in the private sector. There's no way we can create it in the public sector in the time and complexity that's needed. Thank you.
Thank you, Mary. And there should be a little button at the top with a video camera. Tech support says that access should now be better for the activating video, because I was hoping to go back to you on the next question. I love the fact that you actually brought into your answer what Dr. Forgani was saying at the beginning about the importance of collaborating with the ones who are inventing the technologies in a much more, no RFPs across the board, but actual co-design with them as well. So over to the next sort of a topic that we want to explore a little bit is the question of leadership. Deloitte recently published a report that I really liked about the importance of courage, and sort of what will it take and how can we lead forwards with what can our healthcare leaders do to accelerate this process? So over to you, Mary, for completing that answer.
Oh, great. And I got my webcam back. We have to remember that healthcare leaders are generally 50 plus years old, and we could get in the way, as I think sometimes happened with I think it was referenced by you, Alexandra, that we didn't really do a great job in terms of introducing the electronic health record. As a matter of fact, we're still trying to get that right. It's taking much, much longer than it should, given what a foundational part of our system it is. And so healthcare leaders need to become educated, and if we don't know much about AI, it's going to be hard to really promote it, advocate it, invest in it, trust it. And I would take that even a step further and give you a little scenario of the boards. So most of us work under health authority or a health system, a politically appointed board. And those political appointees aren't necessarily appointed because they're strategic for large, complex, digitally enabled organizations like ours. They're appointed for other reasons. So they may also not understand, and they may be looking for ROIs in the next 5 years, which maybe AI can't guarantee, can't. So there's a lot of education to be done with healthcare leaders, with boards, with politicians, to understand what problem are we trying to solve, which, as you can tell from my comments, I think it's really the big resource issue. How do we do what we need to do with a limited workforce that's going to become more and more the barrier to this? So it starts with education, in my mind, of that leadership team. But in the very, very short term, there's a lot of experimentation that we can do in the very little AI, more like robotic process automation that doesn't have much intelligence or much risk in it, but are things that are opportunities even right today that we in the healthcare sector have not done to any great extent.
That's great. And so when you say little AI, it's usually the human in the loop. So a human always verifies the beginning, the middle, the end of the process. And so, but we automate and make easier something that humans don't like doing anyway, right? So I will get Dr. Carr and Dr. Resnick to jump on video as well and complete a little bit more of that sort of a what will it take, because the healthcare system was under strain already before COVID. It's now in crisis mode with COVID. So it takes leadership, but how do we make that happen in a daily reality of a busy role that I know, Dr. Carr, you're currently leading an entire organization that is focused on delivering today. How can we get it ready to adopt some of these new technologies for the future?
Well, that's a huge question, but I actually think we're talking all around it here today. And I think as leaders in the health system, there are a couple fundamentals that we have to keep really in the front of our mind. Number one is to make sure that we keep some focus on, as has been said, not just what is really interesting and where might there be some interesting opportunities, some really cool stuff, but actually where is going to be the greatest impact, where are we going to generate the most value as a system, whether that's in creating a different resource environment, or whether that's in understanding how we can have the most impact in terms of the most people, and particularly some of the populations that might not that we might not be serving well. And I think that implicit in that is not just to be thinking about it from the point of view of medical outcomes, but also the experiential aspect of care. And so I think that I've heard other speakers talking to the fact that, we really need to approach this from the point of view of, right from the point of design, so that it is more of a person-centered design approach, and that we're really intent on using this to fundamentally change kind of the way that people, the outcomes that we accomplish, the value in that, and the experience that people are having. I think for leaders, what that also means for us is that we have to have the courage to create a learning environment, because we're not going to figure this all out in one step. As Mary was just saying, we have a record of not doing change really, really well, and so we're going to have to create an environment that is really a learning environment where we're accepting of the notion that we have to make change quickly, incrementally. We expect that not all change is going to be good. We learn from that and we continue to improve. It's an environment where there's a high degree of psychological safety so that people can engage with us, including patients, caregivers, and families. I think that as leaders we have to manage that change process. So AI is going to create a lot of tensions, and we've talked about that so far today. There's going to be a lot of fears. There's going to be a lot of very valid concerns. And I think as leaders we have to try to create a safe environment where we can create confidence and trust that we can manage a lot of those sensitivities, but at the same time keep moving. And the last thing that I think that I'll say, that I think is really incumbent upon system leaders is that we also really need to recognize that a lot of the data that we have very much reflects the way that the systems worked and the way that and the way that we have seen care, which has been largely through an acute care focus. If you think about randomized controlled trials, they have a significant shortcoming in that they are very much because they are controlled, they provide a very limited view of the population and the challenges that we need to address as a system really, I think, are much broader. And so we are going to have to think about how we ensure that there is data that represents marginalized communities, vulnerable communities, underrepresented communities, diversity, et cetera. I think leaders need to step up and ensure that we have that kind of data.
Oh, absolutely. And I think we're going to go back to equitable access to some of these technologies in our last question. But before we go there, Dr. Reznik, over to you on the question of leadership.
Thanks. As I prepared to take on the task force at the college a few years ago, I spoke to individuals around the world, and Dr. Greenhill, you made this comment. We have incredible talent here in Canada. According to a recent CFAR report, in the top 5 in the world. But I guess I didn't put on my red hat with MCGA on it, that we need to make Canada great again. Because what we don't have, I think structurally at least, are the vehicles for AI scientists to integrate into healthcare, especially at the coalface. And AI, it needs to be a team science, absolutely needs to be a team science, and I agree with Mary. We heard loudly from a survey we did with over 3,500 physicians who responded to our survey. They're eager to take part. But, there's a bit of an anti-industry mentality in many of our medical schools. And in order for AI to work and really work, and I agree with Bill Foley's comment that he made, we'll need to systematically encourage the co-development and co-validation of AI between business, between scientists and clinicians working together, in an ethical framework, but overseen by progressive leadership.
That's fantastic. I think that we're going to open it up for some questions and in a few minutes. So keep coming, comments in the chat. Really appreciate the participation and engagement of the audience. Just finishing off, the last piece that we wanted to capture is almost this introductory set of questions to panelists was the comments about equitable access. And I think Dr. Reznik, you mentioned that. Dr. Risling, you did as well. But we'd love to hear more from Brendan about on your deeper down. You mentioned equitable access across not just acute care. Can you expand a little bit more on that?
I'd be happy to. And I guess I'm just kind of connecting a couple dots here. I think I would say, as a matter of fact, much of the data that we use as a health system is data that's derived from hospital information systems, and to a large extent, we have a huge blind spot as it relates to understanding various segments of our population, demographies, many different things. And when you connect that to another dot, which has been made, I think it was Tracy that said it is, and AI is only as good as the data set that is being, being used. So when you put those two facts together, there's a big risk for us that in fact what we see as the value coming out of these, the AI, machine learning, whatever, it could actually be seriously undermining some important principles of healthcare in Canada, and so I just think that we need to be very, very aware of that, and I think we're going to have to be very conscious of ensuring that the data sets that we're using as one small piece of this are actually representative and reflective of. Now, I don't know how to do that. I'm not a data scientist, but this is an example of where AI and where it's not just about where we have to work in a fusion between from kind of data science and healthcare. I think the other thing is that in terms of how AI is introduced into the system, I think that there will also be some natural tendencies for AI to be used in research-intensive environments and highly specialized areas. We've focusing on personalized medicine, and I think that that's all fantastic and insufficient. And so somehow we need a strategy as a country and as provinces that will ensure that that when we're looking at the utility of AI as a system, that there will be a perspective brought to bear around impact on a kind of a needs-based approach, or understanding where the great, from a population perspective. And so I would be interested to know what people think, but it seems to me that we will need some way to look at this that is not just being driven by everybody's, most interesting and compelling need, but rather kind of more from a societal, from a population point of view.
That's a fantastic segue too, Annette. And then I'll have Dr. Forgani join us back on camera for closing off that section of the panel. But to Dr. Reznik's comments about Canada's leadership role, Health Canada was actually one of the first ministries or government bodies to introduce a vetting and validation process for health AI. And so we'll put in the link of that as well in our comments. And so Annette, you're back on video, which is awesome.
I'm back on
over
video.
to you for a quick comment about, how can we make sure that AI reflects what patients and society need?
Well, I think what the healthcare needs is a lot more patients and caregivers involved. And I think federally the strategy for patient-oriented research has been a big enabler of patients in giving us a lot more knowledge and including us as partners in research. So, but equitable access is a political issue, and it concerns the social determinants of health as well. So how can patients and healthcare providers ensure everybody's inclusion in policy setting so that the time gained through the use of AI is used to increase is not used to increase the volume of patients that providers have to see? And also, if the gateways to healthcare were going to be based on artificial intelligence, how could every patient benefit? Patients need to be more than just literate these days. We need to be health literate, and we also need digital literacy, as well as access to technology. And not everybody has that. I mean, it's easy to sit here in a meeting where we can see one another and not think about the people who need a bridge built so that they'll be able to be part of these changes. I'm concerned. I find it encouraging that CFHI, excuse me, has an advisory group on artificial intelligence that does include the whole range of people, from the patients to the decision makers. And I'd say that including patients as well as providers in the creation of policy is a good start.
Thank you. Thank you so much, Annette McKinnon. And over to you, Dr. Forgani. Oh, you're on mute. Okay.
Oh, do you hear me now?
Yeah, we can hear you okay now.
Okay. I think to be successful, we should focus on where we have strengths and not limitations. It's very great that you have a patient here. One thing is that, we talked about co-design and we talked about domain knowledge. Those are key. But I would extend that more. Maybe we should actually try to seek actual successes. Maybe not as sexy. Look, I do a lot of very sophisticated things trying to predict a molecular tumor phenotype using imaging. But some of the early achievables are not those. Some of the things, there are things we can do to help patients in the very near term. Some of these are, to be honest, not even completely AI, but I think this is how to engage a population. I have to tell you, I have an elderly mother. And whenever she has to interact with the healthcare system, I'm not particularly proud. Actually, I'm more on the ashamed side. It has always made me wonder why she has to go to a doctor just to have a blood pressure taken, when the virtual care, which is really bringing a doctor in a realistic, cost permissive way to a patient's home, has been there for the longest time. So if we go for it goes back to some of the basic things, getting people who actually use it, people who understand the barriers, because as we discussed, the barriers are not all things that can be put in a mathematical formula. Anyone who's worked in a hospital knows a lot of these barriers are actually not logical. So it doesn't surprise me. So we have computer scientists in the hospital, and I'm sure they're very frustrated, but I wanted to understand that. Because unless we overcome those, we will not. And the other thing is the practical aspect. For example, do we get a nurse or some other health professional or assistant go to a patient's home? Is that our model of care delivery? these things can have so much more impact. And I do think that if we focus in an area where, then we can have successes and build on that. And it goes back to all the other important things that were mentioned. Having the right partners, having the correct industry partners, making sure that this is a true collaboration, and honestly seeking some changes. But I do think we need to invest in our health IT infrastructure, because without that, all of this is theory.
Thank you so much for that. And so we would not be panel reflective of the times if we didn't throw in a last round around how all of this has been changed because of COVID. So, a minute each to comment about some of the changes that you've seen, and then we're going to open it up for questions from the audience. And there were many questions submitted, so I'll have to try and triage or combine some of them. But, there was a number of comments made that I personally resonate so deeply with me. I think that the questions of how do we extend the AI capacity to data we don't have or don't see. And so some of those social determinants of health, my patients get better when in the clinic they arrive with somebody who is with them. And so having a person, like in your case, Dr. Reza, taking care of your mom, your presence there is one of the reasons why her health care will be better. And the other one is the ability to have a clear plan of action and remove some of those very simple little obstacles, like knowing where and how to access services, in particular during COVID. And so the question that we were asked to think about is how has COVID changed things? And it's been amazing to see. We actually used technology developed in AI for the trucking sector that matches delivery requirements against trucks that are available, to repurpose that in 6 weeks when COVID started with a Scale AI grant to match volunteers who are available to do rides and deliveries of meals to elderly in the community. And so that's not future Tense AI, that's current Tense AI. And one of the other initiatives we're working on with partners is the idea of donate your devices. A third of Canadians have a device they don't use at home that has a video camera capacity that we can then distribute through community organizations to people who don't have device, and telehealth companies are coming forward with licenses to pay for access. And so it's that idea of equity that let's not leave any Canadian behind as we improve the system is so critical. So I will ask Mary Ackenhausen to come back on video, but maybe we can start with you, Dr. Forghani, 60 seconds on how things have changed after COVID.
Some of this will be a little bit of a repetition, but really I think COVID highlighted the need for more adoption of technology. And that became immediately apparent when it was not safe for much of the population, especially the elderly, to just show up to a clinic for very routine procedures. So I think if we can sometimes get something out of a crisis, we should understand and invest in our health IT structure. And I think this can be done in a truly cost-efficient and sustainable way if you look at long-term outcomes rather than just short-term 6-month outcomes.
Great, thank you. Mary, over to you.
I don't know if you can see me. I can see me.
We can.
If you look at what's allowed us to be successful, this amazing COVID response that we've had, we're big, monolithic, fumbly kind of healthcare system, and yet we've been nimble and agile for the last 9 months. And really there's 3 things that come from organizational literature that we've achieved so quickly. And our question will be whether we can continue to achieve that for AI and other big problems. So one, we were totally aligned around what our purpose was. We knew our purpose was to flatten the curve for COVID. I mean, that was really what we had to do. So all hands on deck for that. Secondly, we needed to execute really well. Well, I know many health organizations perhaps all changed their management structure, basically. They went into emergency operations command and control kind of mode and just got it done. But in the same sense, any idea was a good idea. So we had adaptability at the same time. So we were able to innovate. We were able to kill project innovations that weren't working well, bring another one forward. Again, all to the common purpose of flattening that curve. So I talk a lot about this because I don't think we recognize and talk enough about what we did well during COVID or are doing well, and how that needs to be retained into the future. So will COVID just be a diversion from our thinking on these big problems like AI? Or will it have been an opportunity to learn to manage our system better so that we can be much more focused and accelerate the important things that are going to make our system high quality and sustainable. That's a pivot point that we're at right now, I believe.
That's great. Thank you. Dr. Resnick, over to you about the change after COVID.
A colleague of mine, a member of our task force, Brian Hodges, gave a talk recently on AI in healthcare, and he quoted the director of Educational Technology Innovation at UHN, a gentleman, David Wilger, who said, in his view, the promise of AI has not been fulfilled against the fight of COVID from three perspectives: an epidemiologic perspective, a diagnostic perspective, and also the pharmaceuticals perspectives. And he felt that that was due to the challenges of readiness in leveraging these tools. And for proper leveraging, we need both data science for development and validation. We also need delivery science, including education, operational leadership, and clinical support. We all know that AI is only as good as the data that is put into the algorithms, and I think it's fair to say one of our major challenges in Canada is the development of unified, national, integrated clinical databases that we really just don't have right now, but are absolutely critical and need to be deployed easily, especially at a time of national crisis like we're experiencing now.
Sorry, Dr. Greenhill, I think you are on mute.
Oh, I am on mute this time. Look at that. That's a human error. So, thank you. I was saying that, we promised a bit of a balanced perspective and a little bit of debate. I love the fact that, we can look at the good things that have happened since COVID and how well we've reacted, but also acknowledge that we could do better and how do we actually sustain that and going forward. So I will invite the rest of our panelists to go on video. And so, Annette, over to you for a quick perspective on how do you think things have changed since COVID struck?
Positive side, COVID has accelerated the move to virtual care. So some of us are getting access to doctors in novel ways. But you need to wonder what happened to the patients who were part of the 45% decrease in visits to family physicians in April this year. Are some of them part of the sharp rise in people coming to hospitals with advanced cancers? AI could tell us who's missing and what their common characteristics are, who's falling through the cracks. And I can't see why we're not using it to give ourselves, in Ontario at least, real-time access to mortality data. On the other hand, there's the spotlight on long-term care, where 1 in 4 people who contract COVID die. And the other residents are forced into isolation that's been fatal for some of them. So I'd ask why we're not using AI to deal with complex, present, and looming problems. What will we do with a pandemic once we've got baby boomers entering the stream as well? This is not a heavy-duty time for long-term care considering the future, and yet we've got 35,000 people on the waiting list. Even though people are dying, 1 in 4 are dying, I'm seeing a lot more ads for retirement homes, personally. So I think it's, I can't see how they can ethically continue to operate without changes to the existing model in long-term care.
Burning platform for sure.
Yes.
Dr. Carr, over to your perspective of what you're seeing out in the eastern Canada and also the changes with COVID. The Nova Scotia has been one of the, winners of the zero, for a long time, or tight control. So tell us more about what and how has been implemented, but also did AI play a role, or how can it play a role going forward?
Well, I think Atlantic Canada has benefited from having a smaller population, having a larger geography, and just not having the density that many of our partner communities have, and so the notion of the Atlantic bubble was a smart thing for our chief medical officers of health and premiers to figure out early on. to answer the question, what is COVID in terms of how has it identified opportunities for AI? I would just say in so many ways. And I think maybe the thing that would be most tangible, from my point of view, would simply be, we faced a challenge that has prohibited us from face-to-face care. So being able to use technology in a smart way to continue to deliver care. We've been extremely challenged, I think, as Mary has pointed out a couple times, in terms of our health human resources, and that will continue post-pandemic. So how can we use intelligence to essentially extend, lever, make good use of the human resources that we have? There's so many examples where AI can and probably has been used. I think of practically of like the whole understanding the dynamics of transmission, of contact management and tracing. I really feel that we have underused technology. When I look at the way that we're doing it in a very old school human way, and I think it would be such a good opportunity to be using the power of not even probably full on AI, but just machine learning to support just stuff. And this is probably another good example where we've been inhibited though by concerns around privacy and stuff like that. So maybe an interesting question for us to look at, because I think that there are huge opportunities for us. And in a very tangible way, if we had the ability to use technology to manage contacts and tracing, we probably could have dramatically reduced the number of infections, the number of people in the hospital, the number of serious illnesses, and the number of people who've died. And so that is a compelling case, and I don't know that we've done a good enough job with it.
Thank you, Dr. Carr. And Dr. Isling, over for a perspective for both the nursing and also Saskatchewan, sort of a middle of the country. What and how has changed in terms of COVID, in particular AI, either current or future adoption in your mind? Uh-oh, I think you may be on mute. Hear you.
No?
Oh, now we can, yes.
Now we can. Okay, technology. Thank you. Technology win. I think one of the really important lessons that COVID has taught us, and there's been so many excellent points made, so I've been crossing off my list of items, but I did find one that was left, and that is the power of communication and messaging, especially for both clinicians and for patients and for Canadians at large. Clear communication and messaging is going to be essential to the collaborative advancement of this AI healthcare future. So we've seen the challenges, right? The infodemic challenges, misinformation challenges. And there's actually already a lot of misinformation out there about AI and AI in health and AI in health in Canada, right? It gets intertwined with all of those sci-fi singularity type of messages very easily, especially when you consider platforms which deliver information to Canadians, including social media. So I think it's really managing this has really given us some excellent guidelines about how we'll want to engage Canadians in a discussion about an AI healthcare future in a really clear, concise, and agreed upon way. And one of the other things I think is I think we're emboldened by, I always say, lots of us spent years and years and years trying to advance certain things, only to face barrier after barrier. We can't do this because of this or that, only to see all of those barriers, somehow somewhat magically fall away when it was urgently essential that virtual care overcome those barriers because of the pandemic. So I hope we're emboldened by that, right? To when we start to face those same barriers now, when we say, okay, co-design has its challenges and its expenses, but we know that it has the power to really deliver, especially when it comes to AI and healthcare. We need to not take those same no's for an answer, or not to stop at those barriers when we know that we need to take advantage of the opportunities that exist now to put these kinds of systems in place to build these co-design foundations that are going to see us into that promised bright and somewhat shiny future.
That's great, Doug. So I'm going to go over to questions from the audience in the next few minutes. I see one from Cindy Flores, which kind of resonates on a few things that people have mentioned. It's the need to be experiment-focused to enable local ideas and sort of action, but also the need to balance that with the need for standards and national approach. And so how can we both enable local innovation but also not reinvent the wheel in every jurisdiction and create sort of national systems, where in the past some of these conversations have become, a blocker because, the agreement at the national level has stymied progression locally. And so I think, Dr. Carr, you mentioned something about that, and then maybe I can go over to Mary Ackenhausen for another perspective, so from one coast to the other.
Yeah, no, it's a very good point, and I wouldn't presume to have the solution, but it seems to me one of the threads in our conversation today, though, has been, I think, a sense of agreement that we do need some national approach to data standards, understanding, and so there will be things that need to operate at a national level, but I also think that we need to approach this from a learning point of view through a lens of spread and scale, and we need to we need to kind of create many different laboratories across the country where we're learning things, and we need to though do that with intention and intentionality that says when we learn things we will also be trying to figure out where the leverage points are around scale, and we should be creating mechanisms to do that in a way that and so that we can just accelerate our learning. So yeah, but I think it will be complex, and I think you're right, Alexandra. We have historically allowed silly stuff to kind of get in our way, stuff that is not really helping patient care, and we need to have courage, and I think we have to have tenacity. So.
I love the comeback of courage and tenacity. Mary, over to you. Can't hear you.
Muted, Mary.
Can you hear me now? I'm not muted. You can, okay. I think Brendan gave a great answer. I only have a few things to add to it in terms of, where we start. I think we don't have much of a track record, maybe not any of a track record. I've really been able to do things well in a centralized manner across Canada, so I don't think this is the time to think that it's going to be any different. So if there's one focus in terms of, how we can come together on this as a country, it would be around the data and the integration of the databases and making sure that that there are some standards there. Otherwise, I think we just have to dive into it, at least at a provincial level, and get as far as we can. One of the things that might help, not because we necessarily need the money, I'm always one to say that if it's important, you don't need to wait for the federal government or the provincial government to come give you money to do it. You should be doing it anyway because it's so important. You can allocate money from other things that are less important. However, it is helpful to have money in the sense that it signals the importance of this, because right now, there's nobody saying that AI is important and that we expect every province to be diving into this and getting ahead of it. It's a conversation, which is where everything starts, but there may be some signaling that the federal government can do to show how important this is to the future of our country in terms of healthcare.
Well, absolutely, and the CFAR reports that are coming out are emphasizing that unless we develop a learning system in healthcare, something that can continuously, rapidly improve things, we're going to be stuck. So I was going to go very quick. I'll do two more questions. One of them has to do with that sort of idea of a learning system and experimentation versus the need for us to have evidence that's strong enough with controlled studies. And so maybe Dr. Reza and Richard can comment on that. How do you see the future of science and sort of publishing and the need for rigor versus the much more just-in-time, let's get it done perspective that is being pushed for with AI? Dr. Fugani, I think you're on mute. Still can't hear you.
If you're going to, these are sort of medical devices, and indeed I sometimes get nervous when people make an app unvalidated, unaware bias, and start applying it to clinic. I do think we need to actually apply the same norms we put for other medical devices there. And to be honest, I think we have a lot to learn from the pharmaceutical industry that many years ago learned they have to standardize, have rigorous processes, and this is something that will be led nationally. But, we should also everyone focuses on the diagnostic things. And, a lot of our healthcare inconveniences when it comes to patients and access are process-related issues. The process-related issues are not only easier to achieve, but actually they have much less regulatory burden. So again, when it comes to delivery of care, I think we should also focus on those, not just the sexy, I'm a radiologist, I'm going to diagnose this, but let's actually make things easier for patients. Also, I'd like to make a comment on your last thing. I have to say that as much as I like the idea of national central, I've become disillusioned. I think we need to empower more local. And also, I think it's incumbent on physicians. We're in a very privileged position with lots of influence on healthcare policy. We need to push change a little more, even if it's uncomfortable. And if not, disruptors will come and do it for us. And to be honest, I welcome them because my kids will also need good healthcare after I'm done. So I think we need to continue to be leaders, not only in the medical part, but in the overall part.
Excellent. Quick follow-up to that, Dr. Resnick?
Can you hear me?
Yes.
Yeah, good, great. So I don't think they're necessarily, your two questions are mutually exclusive. I think it would be a national tragedy if we don't capitalize on the brilliance that we have in AI in the country. As we heard before, we have amongst the world's best. But what we don't have is a national strategy and a commensurate national investment. So while I understand the need for local initiatives, we have lots of those. I think what we need now, most importantly, is to, in the words of a former healthcare minister, is to not be a country of pilot projects. We need some big, audacious goals, national goals that are well-funded, well-supported, and capitalize on the talent. And I think the will that the clinical community has to join in partnership with our AI scientists in developing strategies that will be work for our patients.
Well, last word to the patient. I see a question from Anne-Marie Corker. Annette, if you can maybe just comment on the patient perspective where you have so many forms repeating the information repeatedly. What is your wish for a profile that healthcare groups can use and report on?
Well, that would argue for standardized data formats and EHRs, electronic health records that can talk to one another. If everybody had access to the same record, if patients had a role in designing it so that we had our brief history of our illnesses and issues right up front so that the doctor didn't have to go through 40 pages to find out what's relevant, we'd be going a long way. So I'd like to see a push for a simplified and common and readable, and by that I mean readable in different parts of the country, in different hospitals, and in different places. So total interoperability along with the simplicity. And with a one-payer health system, even though it's split up 12 ways, we should be able to achieve that. That's one of the strengths in Canada.
Well, wonderful words to finish on. I see Christine is back on. I think we're about to wrap up. I think we can continue this conversation for many more hours with the caliber of panels that we have, and the discussions in the chat are fantastic. We will send out the links from here with the webinar slides and other content, and this is just the beginning of a conversation. We intend to have many more of these over the next few months. Thank you so much to all the panelists who made time to prepare and share their thoughts today. And over to you, Christine.
Thank you so much, Dr. Greenhill, and to all the panelists. Wow. I feel like I agree. We could keep talking for some time. We just sort of scratched the surface. Thank you for starting us to set the context, saying to the panelists or reminding us about the importance of data and digital literacy, access the importance of co-design and partnership. That really resonated with me, and I would be really remiss, too, if I didn't recognize some of my Pan-Canadian Health Organization colleagues at CIHI and InfoWay who are also looking at some of these really important issues. Just shows us how complex and interconnected everything is. And also, to our panelists, we're really raising the importance of that leadership imperative. So I think maybe it was Brendan who talked about having the courage to create. And to create that learning environment and create that safe learning environment. So as you said as well, Alexandra, we're just starting. We could keep going. So I want to invite you to join us again in January, in the new year. I can't believe I'm saying that, new year, 2021. January 19th, we will have another webinar on this topic where you'll hear reflections and lessons learned from implementing AI in Canada's health sector from a variety of early adopters and innovators in this space. So in the spirit of quality improvement, please I invite you to help us learn about how we can offer these types of opportunities even better. So take a few moments to answer a couple of polling questions at the end. And thank you once again to all of our panelists and to you, our participants. That concludes our webinar today.
This concludes today's webinar. Thank you, everyone. You may now disconnect.